2,400 years ago, deep in Peru, someone died with a massive dark tumor on their skin. And today, we just call it melanoma. Welcome to today's deep dive, everyone. Whether you are a medical student, maybe a young healthcare professional, or honestly just an insanely curious, self-taught learner, we're glad you're here.
Yeah, thanks for having me. And it's wild, right? Because we tend to think of cancer as this modern curse, like it's a byproduct of the industrial age, or I don't know, our modern obsession with tanning beds.
Right, exactly. But surgical oncology has actually been waging this war for millennia. Those ancient radiocarbon-dated Peruvian mummies, they actually show melanotic skin masses and even diffuse bone metastases. So the disease was just as aggressive back then as it is now.
Oh, absolutely. And the historical record of us trying to, physically cut this disease out of the human body it's a pretty brutal timeline. It really wasn't until around 1787 that John Hunter first operated on metastatic melanoma.
And he didn't even know what he was looking at, right?
No, not at all. He didn't have the vocabulary. He famously called it a cancerous fungus excrescence, which is quite a term. We operated in the dark for a really, really long time.
Which is exactly why today's deep dive into Claire Berry's 2019 textbook, Principles and Practice of Surgical Oncology, is just so incredibly compelling. Our mission today is to explore the entire evolution of surgical oncology.
Yeah, how the field basically transformed from a blunt, almost desperate instrument into this highly precise, multidisciplinary science we have today.
Exactly. We are going to build a comprehensive framework for you on how surgeons diagnose, stage, and physically remove cancer today. We'll be looking at the actual biological mechanisms that dictate, literally every cut of the scalpel.
And starting with the surface of the body, with skin cancer, is just the perfect way to understand how environmental factors translate into surgical problems.
Right, because after John Hunter's early attempts, there was an English physician named William Norris. This is around 1820, I think.
Yep, 1820. He began to truly connect the dots. Norris was actually the first to link melanoma to pale complexions, nevuge, which are moles and familial predisposition. He recognized that environmental exposure and genetics were collaborating to cause the disease.
And today, we know exactly what that environmental exposure is doing at a molecular level, which is fascinating. When human skin is exposed to ultraviolet light, specifically those UVB and UVA wavelengths, it directly damages the DNA inside the skin cells.
Yeah, the radiation literally forces adjacent pyrimidine bases in the DNA sequence. So imagine two thymines sitting right next to each other on the strand. It forces them to chemically bond together instead of bonding across the double helix like they're supposed to.
And those are called cyclobutane pyrimidine dimers, right? Or CPDs.
Exactly, CPDs.
Yeah.
And those CPDs create a physical kink in the DNA strand. It's a structural distortion. So when the cell tries to replicate, that kink causes genetic mutations.
Wow.
Yeah. And if those mutations happen in the genes that control cell growth, well, you get unchecked proliferation. And the risk factors tied to this mechanism are just staggering. Using canning beds before the age of 30 increases your risk of developing melanoma by 75%.
75%. Because you are actively, bathing your cells in radiation that distorts your genetic code.
Exactly. You're intentionally creating those DNA kinks.
Which means detecting that proliferation early is critical. So for learners out there, we rely on the classic ABCDE mnemonic to spot early melanoma.
Right. So that's asymmetry in the shape, borders that are irregular or jagged, color that is variegated, so multiple shades of brown or black, a diameter greater than 6 millimeters, and most importantly, evolving. Any change in size, shape, or symptom over time.
But there is a dangerous variant called nodular melanoma that completely ignores those rules, doesn't it?
It really does. It sneaks up on you. For nodular melanoma, you have to look for EFG. That stands for elevated above the skin surface, firm to the touch, and growing steadily.
Okay, so once you spot it, when a surgeon intervenes, the gold standard is complete surgical excision with clear negative margins.
Yes, negative margins are everything. You want a buffer of entirely healthy tissue around the tumor. You want to know you got it all.
It makes me think of cutting a bruised, rotting spot out of an apple, You always cut a little bit of the healthy, crisp apple around the rot just to be absolutely certain you didn't leave any microscopic rot behind to spoil the rest of it.
That is a perfect analogy.
Yeah.
But for non-melanoma skin cancers, specifically basal cell and squamous cell carcinomas that show up on highly sensitive areas like the face, the neck, or the hands, A standard wide excision can be really problematic.
Right, because you don't want to cut away massive chunks of someone's eyelid or nose.
Exactly. And this is where surgeons employ Mohs micrographic surgery.
And the mechanics of Mohs are just incredible to me. It feels less like standard surgery and more like, I don't know, diffusing a bomb by cutting the wires 1 millimeter at a time.
That's exactly how it feels. The surgeon removes a very, very thin layer of tissue, and then while the patient literally waits right there, that exact tissue is mapped and evaluated under a microscope.
They are checking 100% of the surgical margin.
100%.
Yeah.
If the pathologist sees cancer cells on, say, the north edge of the sample, the surgeon goes back and takes another millimeter only from that northern edge. They repeat this real-time histopathology loop until the entire circuit board is totally clear.
But wait, I have a question about that. I mean, Mohs sounds incredibly precise, obviously, but is it logistically exhausting for the patient and the surgeon compared to just, say, a standard excision or cryotherapy where you just freeze it with liquid nitrogen?
Oh, it is extremely time-consuming. It can take hours. But it guarantees maximum preservation of healthy tissue alongside complete tumor removal. Cryotherapy destroys the tissue, right? Meaning a pathologist can never actually verify if microscopic disease was left behind. On a complex structure like the nose, sacrificing unnecessary healthy tissue with a wide, blind excision is just something we want to avoid at all costs.
That makes total sense. Now, that intense focus on microscopic margins right at the surface of the body shifts pretty dramatically when we move deeper. As we transition to looking at breast cancer, we move from managing local surface threats to predicting and intercepting systemic ones.
Right, and this is where staging fundamentally alters the surgical philosophy. Staging is basically the bedrock of oncology.
And we use the TNM system for that, right? Tumor, node, metastasis.
Exactly. The staging dictates everything we do. We evaluate the primary tumor's characteristics, the T whether cancer cells have drained into regional lymph nodes, the N, and whether it has metastasized to distant organs, the M.
So the surgical mandate for a highly localized, early-stage cancer is going to be entirely different from one that has systemic reach.
Night and day difference. Let's break down the tumor sizes in breast cancer.
Yeah.
We have T1, which is 2 centimeters or less. T2 is 2 to 5 centimeters, and T3 is anything greater than 5 centimeters.
And then there's stage 0, something like ductal carcinoma in situ or DCIS. In that case, the abnormal cells are entirely contained within the milk ducts, right?
Yes, and because it hasn't invaded the surrounding tissue, it boasts a massive 98% 10-year survival rate. The goal there is highly curative.
But the moment you find a positive sentinel lymph node, which is like the very first node the tumor drains into, you are suddenly fighting a war on multiple fronts.
That's the turning point. The cancer now has access to the body's transit system. And of course, stage 4 indicates distant spread, where the approach is much more systemic. The surgical options scale directly with that threat level.
So we have breast-conserving options first, like a lumpectomy.
Right, removing the tumor and a margin of healthy tissue, or a quadrantectomy, removing about a quarter of the breast.
And if the disease is more extensive, you're looking at a mastectomy, removing the entire breast tissue. But surgical oncology has really advanced here with things like skin-sparing and nipple-sparing mastectomies.
Yeah, those are incredible advancements. The surgeon removes all the underlying glandular tissue, but preserves the external envelope. It drastically improves reconstructive outcomes and the patient's psychology, all without compromising oncologic safety.
But genetics completely upend this reactive approach, don't they? When we look at the BRCA1 and BRCA2 gene mutations, we are basically looking at broken tumor suppressor genes.
That's exactly what they are. Normally, these genes repair DNA damage like fixing the very DNA double-strand breaks, those CPDs we talked about earlier in skin cancer.
Right. And when you inherit a mutated version of BRCA, your cellular repair mechanisms just fail. The risk for breast, ovarian, and even pancreatic cancer skyrockets. I mean, pancreatic cancer can actually present a full decade earlier in BRCA carriers compared to the general population.
Which is terrifying. And the implications of that broken repair mechanism have led to what I think is the ultimate paradigm shift in surgical oncology: prophylactic surgery.
Preventative surgery.
Exactly. For patients carrying high-risk BRCA mutations, we don't wait for the cancer to form. The single most effective preventative method is the surgical removal of the at-risk tissue before it becomes cancerous.
So we're talking about prophylactic mastectomies and prophylactic salpingo-oophorectomy, which is the removal of the ovaries and fallopian tubes.
Yes.
I have to push back on the philosophy of this a little bit, though, because removing entirely healthy, disease-free organs, especially organs tied to hormones and reproduction, I mean, it feels almost like a radical admission of defeat in our preventative medicine arsenal. Are we saying our screenings and targeted therapies are just so inadequate that amputation is our only answer? Or is this actually the ultimate surgical triumph because we can definitively stop a disease before it starts?
I get that perspective, I really do. But it is absolutely the latter. It's a triumph driven by the ruthless realities of predictive biology. The truth is, we simply do not have a reliable, non-invasive screening tool for early-stage ovarian cancer.
Oh.
No.
Yeah.
By the time it appears on a scan or causes symptoms, it is almost always advanced. For a BRCA carrier, those odds are a ticking clock. Intervening surgically is the most definitive way to save the patient's life based on genetic foresight.
Wow. Okay.
And to underscore just how critical this is, during these supposedly preventative ovarian surgeries, pathologists discover undetected microscopic cancer already forming in about 5% of patients.
5%.
Yeah. So it is a radical intervention, sure, but it is deeply justified by the biology.
That is wild. Well, that transition from preventing cancer in healthy organs to dealing with silent, deeply embedded tumors brings us to arguably the most complex terrain in the human body, the abdominal cavity.
Oh, definitely. Gastrointestinal and pancreatic cancers hide in the dark.
Right. They present incredibly late, and treating them requires some of the most massive anatomical rewiring in all of medicine. Let's look at pancreatic cancer.
Pancreatic cancer highlights this perfectly. The pancreas sits retroperitoneal, which means it's tucked way deep behind the stomach. The vast majority of these are exocrine tumors, which are highly aggressive.
Though you also see endocrine tumors, right? The PNETs.
Yes, PNETs, which have a slightly different growth profile. But because of their deep anatomical location, these tumors just grow silently. They're usually only diagnosed late in the game when a tumor in the head of the pancreas grows large enough to physically obstruct the common bile duct.
And that causes the patient to develop jaundice.
Exactly. They turn yellow, and that's often the first real sign.
Now, when a tumor is located in the head of the pancreas, the surgical solution is the Whipple procedure, which is technically known as a pancreatoduodenectomy. And to understand the sheer magnitude of this surgery, I always think of it like completely rewiring the plumbing, the gas lines, and the foundation of a house while the water is still running.
That is exactly what it's like. I mean, the surgeon removes the head of the pancreas, the duodenum, the gallbladder, and part of the bile duct. That's a massive amount of anatomy to take out.
And the removal is only half the battle.
Right. The reconstructive phase requires extraordinary anatomical mastery. The surgeon has to restore the continuity of the digestive tract and the biliary system. So first, they perform a pancreatic gynostomy.
Which connects the remaining pancreas to the small intestine, right? So digestive enzymes can flow?
Yep. Then they do a hepaticogynostomy to connect the bile duct to the intestine. And finally, a gastrogynostomy connects the stomach to the intestine to allow food to actually pass through.
And you are doing all of this within millimeters of the body's most critical vascular structures, like the superior mesenteric artery.
Right. One slip there is catastrophic. The proximity to those blood vessels makes it one of the most high-stakes environments imaginable.
And that level of complexity isn't limited to the pancreas, is it? It applies equally to colorectal cancer, specifically when it metastasizes. Because the liver is the primary filtration system for the blood returning from the gut, it's the most common site for colorectal metastases.
Exactly. When colorectal cancer spreads to the liver, the surgical goal is what we call an R0 resection. That means the surgeon removes the liver metastases, and the pathology report confirms there are absolutely zero cancer cells at the microscopic margins of the resected tissue.
Zero. Just like Mohs surgery on the skin.
Exactly. But achieving an R0 resection in the liver requires mapping an incredibly complex vascular network. Surgeons rely heavily on triple-phase CT scans or dynamic MRIs before they even enter the OR.
Because they need to visualize the arterial, venous, and portal phases of blood flow, right?
Yes. They have to plan their cuts perfectly to remove the tumors while preserving enough functional liver volume to actually sustain the patient's life.
But what happens when the cancer isn't just a discrete, localized mass that you can map out and cleanly resect? What if the cancer has spread like seeds throughout the entire abdominal cavity?
Yeah, that pushes us to the extreme frontiers of surgical oncology: peritoneal surface malignancies and advanced ovarian cancer.
Because ovarian cancer often presents exactly this challenge. We mentioned the lack of screening earlier. The symptoms are just so vague: bloating, early satiety, vague pelvic pain.
Right. They're so easily mistaken for benign gastrointestinal issues. By the time a patient actually undergoes surgery to confirm the diagnosis, the cancer has frequently seeded itself all across the peritoneum, which is the membrane lining the entire abdominal cavity.
And the surgical approach here completely breaks the rules we just established. It's called cytoreductive debulking surgery.
Yes. If the surgeon opens the abdomen and realizes the disease is just too diffuse to ever achieve microscopically clear margins, they shift their entire goal.
They just remove as much macroscopic tumor as possible. They might take the omentum, the ovaries, the uterus, and literally scrape massive tumor deposits off the bowel or the liver capsule. But wait, I have to stop the tape right here. You just told me that in most surgery for the skin or an R0 resection in the liver, leaving even a single microscopic cluster of cancer cells behind is a total failure. You want complete eradication. Why on earth is debulking an acceptable medical strategy for ovarian or peritoneal cancer if you are knowingly leaving disease inside the patient?
I know, it seems entirely counterintuitive, until you look at the biological synergy between the surgeon's scalpel and systemic chemotherapy.
Okay, explain that.
So large, bulky tumor masses actually have a terrible blood supply at their core.
Yeah.
They are necrotic inside and highly resistant to chemotherapy because the drugs simply cannot physically penetrate deep into the mass.
Oh, I see.
Right? So by surgically removing those large resistant fortresses, you are intentionally leaving behind only the microscopic clusters of cancer cells.
Ah, so you clear out the heavily armored bunkers so the chemotherapy can target the exposed foot soldiers.
Precisely the mechanism. Those remaining microscopic clusters are well oxygenated and metabolically hyperactive. And because chemotherapy targets rapidly dividing cells, these tiny clusters are paradoxically highly sensitive to the drugs.
That is brilliant.
It is. And for certain peritoneal surface malignancies, like pseudomyxoma peritoni, which usually originates in the appendix, by the way, surgeons exploit this vulnerability immediately in the operating room. They use a technique called HIPEC.
Hyperthermic intraperitoneal chemotherapy.
Exactly. After the surgeon physically strips away the visible tumors, they literally wash the open abdominal cavity with a heated chemotherapy solution, like mitomycin C.
And they usually circulate it for about 90 minutes, right? But heating the chemotherapy isn't just about creating a harsh environment for the cancer. It has a very specific physiological rationale.
It does. The thermal energy fundamentally changes the tissue response. Heating the chemotherapy to about 42 degrees Celsius causes profound vasodilation. It physically expands the blood vessels in the tissues lining the abdomen.
And vasodilation improves tissue oxygenation.
Exactly. Furthermore, the heat actually increases the permeability of the cancer cell membranes. The chemotherapy agent, which works by cross-linking the DNA of the cancer cells to prevent replication, it can penetrate deeper and act with significantly enhanced cytotoxicity against those remaining microscopic cells.
It's just incredible. Well, from the deep, soft tissues of the abdomen, we arrive at the final frontier in our deep dive today. The literal structural framework of the body, the bones, the connective tissues, the muscles.
Yeah, this is the world of sarcomas.
Yeah.
And here, the surgical objective is not just saving the patient's life, but saving their limbs.
Sarcomas are rare, but they are highly aggressive cancers. Osteosarcoma, the most common primary bone cancer, often strikes children and young adults during periods of rapid bone growth, which is just heartbreaking.
It is. And historically, if a patient developed an osteosarcoma in the femur or the tibia, the standard of care was an immediate high-level amputation. There was no other option.
And even then, the survival rates were still incredibly poor, right? Because micrometastases had usually already spread to the lungs.
Exactly. But today, the treatment paradigm has shifted massively away from immediate amputation. And that is all thanks to neoadjuvant chemotherapy.
Which is systemic chemotherapy administered before the surgeon ever picks up a scalpel. It acts like an artillery barrage, softening up an enemy stronghold before the infantry goes in for the precise final strike.
That's a great way to picture it. The neoadjuvant approach serves two vital purposes. First, it immediately attacks those micrometastases circulating in the bloodstream, securing the systemic front. Second, it shrinks the primary bone tumor and induces necrosis, which actually forms a thick fibrous rind around the cancer.
And that fibrous rind allows the surgeon to perform a limb salvage procedure. They can resect the cancerous bone with clear margins and reconstruct the defect with metal endoprosthetics or bone grafts.
Yes. Today, because of this multidisciplinary approach, limb salvage is possible in about 90% of osteosarcoma patients.
90%. That is a miracle. And even when traditional limb salvage isn't anatomically possible, the biomechanical ingenuity of surgeons is staggering. Consider rotationplasty.
Oh, rotationplasty is fascinating. If a tumor involves the lower femur and the knee joint, the surgeon resects that section of the leg, but they preserve the major blood vessels and the sciatic nerve.
Right. And then they take the healthy lower leg, the calf, and the foot, they rotate it 180 degrees, and they attach it to the remaining upper thigh bone.
It sounds like science fiction, but because the foot is pointing backwards, the ankle joint functions mechanically exactly like a knee joint.
So when they fit a prosthesis over the foot, the patient regains active control and proprioception of their new knee.
Exactly. It provides a vastly superior functional outcome compared to a standard above-knee amputation. It allows many of these young patients to return to high-impact sports. I mean, it is the ultimate intersection of oncologic resection and biomechanical engineering.
It is absolute genius, and I think it perfectly encapsulates how this entire field has evolved. Let's briefly recap our journey today. We started with the ancient reality of melanoma and the modern microscopic precision of Mohs surgery, literally mapping cellular threats millimeter by millimeter.
Right. We explored the genetic foresight of BRCA prophylactic surgeries, intervening before a tumor even forms.
We broke down the massive anatomical rewiring of the Whipple procedure. We talked about the synergistic chemical baths of IPEC targeting exposed cellular foot soldiers, and finally, the biomechanical miracles of sarcoma treatment. It's clear that surgical oncology is no longer just isolated cutting. It is deeply integrated with chemotherapy, radiation, and genetics.
It really is. And as we wrap up this deep dive into Claire Berry's textbook, I want to leave the medical learners in the audience with a clinical review question, just to solidify the physiological mechanics we discussed today.
Good idea.
So, think back to the abdominal cavity. In the treatment of peritoneal surface malignancies using AGPEC, what is the physiological mechanism by which heating the chemotherapy agent improves its effectiveness against cancer cells?
Give everyone a second. Think about what heat does to a vascular network.
The answer is, eating the chemotherapy causes vasodilation, which improves tissue oxygenation and simultaneously increases cell membrane permeability. This directly enhances the penetration and cytotoxicity of the drug against those remaining microscopic cancer cells.
It's a brilliant exploitation of human physiology.
Absolutely. And I want to leave you, the listener, with a final thought to ponder. We have spent this entire discussion marveling at the physical removal of disease. The scalpel has never been more precise. But as systemic therapies, immunotherapies, and genetic engineering become exponentially more capable of hunting down cancer at the individual cellular level, we have to ask, will the physical cutting out of cancer eventually become a barbaric relic of the past? Or will the surgeon's scalpel simply evolve again, becoming more microscopically precise, working hand in hand with these systemic cures?
It's a profound question to end on. It brings us right back to the reality that the human body is constantly shifting terrain. The diseases that invade it adapt, and the tools we use to fight them must adapt in turn. But as long as that biologically hostile territory exists, the surgical oncologist will be there analyzing the margins, reconstructing the pathways, and guiding you safely through to the other side. Thank you all for joining us on this deep dive.